blockage of conduction in the anterior fascicle of the left bundle branch is relatively common and is the commonest cause of left axis deviation on the ECG. The fascicle is supplied by septal branches of the left anterior descending artery. Therefore, infarction or ischemia in this vascular territory can lead to left anterior fascicular block with left axis deviation on the ECG. In addition, left ventricular hypertrophy from any cause may on occasion be associated with areas of fibrosis or ischemia within the ventricular myocardium, and this can result in damage to the anterior fascicle. More diffuse myocardial disease processes, such as cardiomyopathies, may also compromise the fascicle, manifesting as left axis deviation on the ECG. In contrast to its compact anterior counterpart, the fibers of the posterior fascicle are widely spread out. This, combined with a dual blood supply, makes it far less likely to be damaged by focal cardiac pathology. It may, however, be involved in widespread cardiac ischemia or in diffuse disease processes such as cardiomyopathies, resulting in right axis deviation on the ECG. So far we have emphasized the role of conduction defects in the left ventricle as the primary cause of axis deviation on the ECG. This is indeed the case, and it reflects the dominance of the left ventricle in determining the cardiac axis. However, we should point out that in some situations other depolarization vectors may come to the fore and shift the axis independent of damage to conduction in this chamber. Some of these are intuitively obvious. For example, in the presence of a large left lateral myocardial infarction with loss of left-directed vectors, the relative contribution to the cardiac axis of depolarization events directed towards the right may become more prominent, shifting the axis to the right. Equally, a large right-sided infarction can shift the axis to the left by loss of depolarization events directed towards the right. Changes in the cardiac axis occurring in association with myocardial infarction is an area we will discuss in more detail in section 3. Before we move on, we would like to emphasize one important point. Although ventricular hypertrophy in the absence of conduction defects is a potential cause of axis deviation, this is very unusual. The great majority of patients with left ventricular hypertrophy from whatever cause do not have left axis deviation on their ECG. Furthermore, and perhaps surprisingly, the presence or otherwise of LAD in patients with left ventricular hypertrophy bears no relationship to the degree of hypertrophy present. The same is true for right ventricular hypertrophy acquired in adult life. The majority of adult patients with RVH do not demonstrate right axis deviation on their ECG. Remember, axis deviation usually results from conduction defects in the ventricles, and axis deviation on an ECG is neither sensitive nor specific in the diagnosis of ventricular hypertrophy. The list of causes we've generated for left and right axis deviation is far from complete, and we will discuss other mechanisms of axis shift in the quiz section. However, the differential may already seem bewilderingly broad. That should not worry you at this point. In reality, you will be analyzing the patient's ECG in clinical context, and there will be clinical clues as to the underlying cause of any axis deviation identified. In addition, if significant axis deviation is present, There are generally other abnormalities present on the ECG which can help identify the underlying cause. Hopefully by the end of this course you will be able to recognize these other abnormalities.